Hello, everyone. My name is Dr. Ronny Bell. I'm a professor in the Department of Social Sciences and Health Policy at the Wake Forest School of Medicine. I am also the chair of the North Carolina American Indian Health Board. I'm an enrolled member of the Lumbee Tribe, and I'm very honored to speak with you today in collaboration with my colleague, Dr. Tracie Locklear at North Carolina Central University. And we're going to be talking with you today about COVID-19 and how it's impacting American Indian communities. So it's interesting to think that a year ago today, actually, as of this recording, North Carolina first identified a case of this new disease called COVID-19, which we were just learning about as it was spreading across the world. And it's also interesting to think that the North Carolina American Indian Unity Conference last year was probably the last public event that many of you attended since things started shutting down in our state and in our country and across the world soon after the Unity last year. So what is COVID-19? Well, COVID-19 is a virus, like many viruses that we have in our world, like pneumonia and influenza and the virus that causes the common cold. But it is a very unique virus. It's one that we first identified in late 2019 in a town called, in a city called Wuhan, China. And so that's why we come with the terminology coronavirus. Corona is Latin for crown. And so you can see the image on the right there that the virus itself has these spikes, which kind of look like a crown. And so, and we used the terminology COVID-19 to indicate that the virus was first identified in 2019. COVID-19 is actually also referred to as SARS-CoV-2. SARS stands for Severe Acute Respiratory Syndrome because this is a virus that primarily attacks the lungs. It is the coronavirus, as I mentioned, but it's actually the second coronavirus that we've identified. The first one was part of the SARS outbreak that occurred in 2003, which was not nearly as impactful as COVID-19. We know that COVID-19, the virus, is very contagious, and so that's why the North Carolina Department of Health and Human Services and the Centers for Disease Control and Prevention have adopted these three public health strategies to try to help avoid the spread. And so the three W's are wear a mask to keep from spreading the virus through talking or singing or any sneezing, any types of coughing, any types of air droplets that can be transmitted from one person to another. We also know that it's important to stay at least 6 feet away from people that you don't know. And that's wait, and then wash your hands. We know that the virus can stay for long periods of time on surfaces, so it's important to wash your hands and use hand sanitizer. So wear, wash, wait, wear, wait. And because this was a new virus, we had to develop testing techniques to identify whether people had the virus or not. And there's really two main types of test. One that detects the actual virus itself, either through a genetic test or testing of the proteins that are on the virus itself, and those tests are done by collecting a nasal swab that you can see there on the right. The other type of test is what's called a serological or antibody test, where you're determining from a blood sample, you're determining whether someone has actually had the virus or not. And we've known, unfortunately, almost from the very beginning that COVID-19 has disproportionately impacted communities of color, and unfortunately that has not only impacted American Indian Alaska Native populations, but also Hispanic and African American populations. So you can see here from data from the CDC shows that compared to non-Hispanic whites, that American Indians and Alaska Natives are 1.8 times more likely to be diagnosed with COVID-19. They're 4 times more likely to be diagnosed with, to be hospitalized with COVID-19, and they're 2.6 times more likely to die from COVID-19. So very, very impactful for our American Indian Alaska Native populations. And there's lots of reasons for that, which have to do with the social and healthcare structures in our country. And so we think about things like pre-existing conditions, so diabetes, high blood pressure, obesity, kidney disease, conditions that are very common in Native communities, put you at increased risk for having poor outcomes once you have had the virus. We also know that poverty comes into play, lack of access to healthcare, and also racial biases in our healthcare system. But the other challenge we have is that we really don't have really great data to indicate how severe this problem is in our Native communities. This is a report that came out a couple of weeks ago from the Urban Indian Health Institute, which indicates that the quality of the data around COVID-19 cases and hospitalizations and deaths is not great. And then we also know that the data in North Carolina, this is a report that came out from the North Carolina Health News in June, actually, that showed that about a third of the data that's collected by the state on screening and cases didn't actually record race and ethnicity. So it's really difficult for us to know how impactful COVID-19 is in our Native communities. Now, fortunately, in addition to the public health mitigation strategies that we have in place, we now have vaccines to help reach what we call herd immunity to prevent the spread of the vaccine, of the virus. And so there's two main vaccines that have been distributed in our communities. The vaccines produced by Pfizer and biotech, and also Moderna, which uses a new technology to help sort of train your body to develop antibodies to fight off the virus. We also have a new vaccine that's just come on the market from Johnson & Johnson. The most recent data shows that this vaccine is not as effective as some of the other two vaccines, but the advantage that this vaccine has over the other two is this is a single shot vaccine, and the Pfizer and Moderna vaccines are double shot. So not as effective, but you don't have the challenges of having to get the two shots like you do with the other two. And our tribal communities have been doing a really good job in getting our tribal members vaccinated. I just saw today that the Eastern Band Cherokee has reported that they've vaccinated over 5,000 of the tribal members there. And the Lumbee tribe has also been working hard to get particularly our elders vaccinated. So there's a lot of great work going on in the community. But I think for lots of different reasons, there are a number of people who are hesitant to get the vaccine. This is something that occurred much more quickly than the way other vaccines have been developed in the past. And I think also because of sort of historical mistreatment by the healthcare system. We know, in particular, Black Americans are somewhat reluctant to get the vaccine. And I'm going to let Dr. Tracie Locklear talk about some of the work that she and her colleagues are doing to better understand the issues around vaccine receptivity in the Lumbee tribe.
The title of my talk is Vaccine Hesitancy in North Carolina, Preliminary Findings from the Advanced Center for COVID-Related Disparities. I am Tracie Locklear, a research assistant professor at North Carolina Central University and a co-investigator on this study. I am presenting on behalf of all of my colleagues, 33 of us in total that are working on this study, in addition to our principal investigator, Dr. Deepakkumar, who is the director of the Julius L. Chambers Biomedical Biotechnology Research Institute at North Carolina Central University. The Advanced Center for COVID-Related Disparities, or ACCORD program, conducts multidisciplinary research to better understand the public health and economic impact of COVID-19 on underserved communities in North Carolina. We conduct COVID-19 testing and survey community participants across North Carolina to better understand community needs, barriers to testing and immunization, and to build and deploy culturally appropriate messaging and educational tools to communities at most risk during the COVID-19 pandemic. This work is funded by the National Institutes of Health, the National Institute of Minority Health and Health Disparities, the North Carolina Department of Health and Human Services, as well as the Coronavirus Aid, Relief, and Economic Security, or CARES Act, passed by Congress in 2020. Originally, we started in 9 counties: Durham, Wake, Vance, Granville, Cabarrus, Warren, Halifax, Anson, and Rowan County. Now we've expanded to 14 counties, including Robeson, Scotland, Hoke, and Cumberland counties. And this work is in collaboration with the Lumbee Tribe of North Carolina. Our work has reached roughly 3 million people and roughly 30% of North Carolinians and is continuing to grow. To date, we've completed more than 3,500 COVID-19 tests, conducted 1,500 surveys, asking participants about the impact of COVID-19 on their daily lives, including employment, attitudes towards testing, vaccination, and concerns about misinformation or trust around vaccination and testing. Our response rate has been as high as 95% at some of our events. When we started ACCORD in August of 2020, the Trump administration had just reached a deal with Moderna to purchase vaccines once the Food and Drug Administration approval had been confirmed. By September 28th, global COVID-19 deaths had surpassed 1 million worldwide. And in November, Pfizer and Moderna were rapidly moving towards emergency use authorizations with the FDA. By mid-December, the FDA had signed off on the emergency use authorizations for both the Pfizer as well as the Moderna COVID-19 vaccines. Between August of 2020 and December of 2020, before Moderna and Pfizer vaccines had received emergency use authorization from the Food and Drug Administration, we surveyed the community about concerns over these new vaccines. During this period, majority of respondents were concerned about the safety of the vaccines. 11% distrusted the government and 24.1% wanted to wait for others to take the vaccine before they would be willing to take it. Between December 19, 2020 and January 30th of 2021, we surveyed community members across 8 counties again regarding vaccine hesitancy. The majority of the participants were between the ages of 40 and 79. 69.5% of the participants were female and 29.9% were male. Across the 8 counties we surveyed, we had a significant proportion of Black participants, 51%, Native American participants, 23.7%, white and Latino participants, 11.6% respectively. 33% of our participants had a high school diploma or less. 27% made less than $20,000 annually, and 19% did not have health insurance. 17% didn't have internet at their homes. When we looked by county, individuals in Wake, Vance, and Granville counties were more likely to get vaccinated than those living in Robeson, New Hanover, and Cabarrus counties. We calculated the level of actionable hesitancy to exclude individuals who stated that they would definitely get the vaccine, which is here indicated in the dark green, and included individuals who said they would probably get it, probably not get it, definitely not get it, or did not know whether or not they would get it. So the light green to gray areas represent the percentage of actionable hesitancy in the population. The lower number represents the percentage of people most likely to decline vaccination. This number excludes individuals that stated that they would definitely get it or probably get it, which is shown here in the dark green and the light green. Robeson County, New Hanover County, and Cabarrus counties had the highest rate of vaccine hesitancy, whereas Wake County and Vance counties had the lowest rate of vaccine hesitancy, as shown here. When we asked participants, once it is available for free, will you take the vaccine? 40% of participants stated that they would definitely get it, whereas 22% stated they would probably get it, 9% stated they would probably not get it, 8% stated they would definitely not get it, and 21% stated they did not know whether or not they would get the vaccine. When we looked at the population across race, we saw that Native Americans and Latinos were less likely to get the vaccine even if it were available for free compared to their white and black counterparts. We calculated the level of actionable hesitancy by excluding individuals who stated that they would definitely get the vaccine. And so the light green to gray areas represent the percentage of actionable hesitancy within the population. The lower number, shown here on the right, represents the percentage of people most likely to decline the vaccination. This number excludes individuals that stated they would definitely get the vaccine or probably get the vaccine. So you can see that the Native American and Latino populations are far more hesitant to get the vaccine, 72% and 74% respectively, compared to 37% and 58% of white and black participants, respectively. Participants were asked to respond to the statement, "I worry about the harmful side effects of a COVID-19 vaccine." And 20% of white respondents agreed with this statement strongly, compared to 37% of Native Americans, 40% of blacks, and 46% of Latino participants. In total, 15% of participants felt that the COVID-19 vaccines were not safe because they had been rushed through the testing and approval process. You can see that displayed here in the purple line. When we looked across the different races, we found that 16% of Native Americans agreed strongly that the vaccines were rushed and were not safe, compared to 17% of Black and 13% of Latino participants, respectively. Only 3% of white participants strongly agreed with this statement, while 32% of white participants disagreed strongly with this statement, indicating that they felt the vaccines were safe and had not been rushed through the testing and approval process. Participants were asked to respond to the statement, "If anyone in our community gets the COVID-19 vaccine, we will be protecting each other." Both Native American and Black participants strongly disagreed or disagreed somewhat with this statement, while white and Latino participants largely agreed or agreed somewhat with this statement. Neither white nor Latino groups disagreed strongly with this statement. Participants were given the statement, "If a vaccine was available, I'd get one to get life back to normal, get people back to work, kids in schools, and people back together with each other." Here again, Native American and Black participants felt similarly about this statement. 5% of Native Americans disagreed strongly with this statement, as indicated here in blue, and 12% disagreed somewhat with this statement. Compared this to 4% of Black participants disagreeing strongly with the statement, and 9% of participants disagreeing somewhat with this statement, as indicated in the red line. Participants were asked to respond to the statement, "I will be much more relaxed once I can get a COVID vaccine to protect me from getting sick." In the total population, 9% disagreed strongly with this statement, 20% disagreed somewhat, 38% agreed somewhat, and 34% agreed strongly. When we look at this across the different populations by race, we see that 11% of Native Americans and 11% of Black respondents disagreed strongly, compared to only 6% of Latinos. 21% of Native Americans and 22% of Blacks disagreed somewhat, as indicated here in red, compared to 17% of Latinos and only 13% of white participants. Participants were asked, "What are the most important things that would have to happen for you to get the vaccine?" 30% of Native Americans, shown here by the purple bar, indicated that they would wait several months to see what would happen to people who get the vaccine first. This response was very similar to our Black participants. These two groups were also more interested in seeing people like them get the vaccine without side effects first. As indicated, 33% of Native Americans and 36% of Black participants responded this way respectively. Additionally, 31% of Blacks and 29% of white participants responded that it would be more important for them for a healthcare provider to tell them to get the vaccine, compared to only 18% of Native Americans and only 10% of Latino participants who felt this way. Time off work was a contributing factor for Latino participants, but did not appear to be much of a concern for other groups. Having the vaccine offered close to home, however, was important for 39% of our white participants, 37% of Black participants, and 30% of our Native American participants, respectively. Only 17% of our Latino participants felt that offering the vaccine close to home or close to where they lived was important. Based on our survey data, we have found that trust in health departments varies widely across the different races, but trust in community health educators and healthcare websites remains high across all groups. To increase the likelihood of vaccination, residents would like the vaccine to be offered close to where they live and would also like to see more people who look like them getting the vaccine. We expect that after a few months, vaccination hesitancy may decrease as more people are getting vaccinated within the community and are reporting few side effects. The Accord team is committed to building trust within the communities in which we work. In addition to presenting here at the 2021 Unity Conference, we have participated in several educational events locally, including at faith-based organizations, health departments, and virtual town halls, and we will continue to do so to share our results with the community. On behalf of all of my colleagues at North Carolina Central University, including the principal investigator, Dr. Deepakkumar, I would like to thank you sincerely for allowing us this opportunity to share with you our findings from the Accord program.